In our last two classes of respiratory system, we have discussed some respiratory diseases which were related to the upper respiratory tract system, right? But today we will discuss some diseases which are related to the lower respiratory tract. So let's start with the first bronchiolitis, acute bronchiolitis. Acute bronchiolitis. So first look at the anatomy. Okay. We have the respiratory tract from the nostril up to the alveolus. We have discussed the upper respiratory tract infection. Now we will start with the bronchiolitis. This is trachea, okay. Then the primary bronchus, then the secondary bronchus, tertiary bronchus, then comes the bronchiole, okay. So the disease of bronchiolitis is here in the bronchiole, okay, just below the or beyond the bronchiole, that is terminal bronchiole and the alveoli. When the disease is in the bronchiole, it is known as the bronchiolitis. But when the disease is here in the alveoli, it is known as pneumonia. Okay. So acute inflammatory condition of the bronchiole, that is a result of viral induced injury. So remember, bronchiolitis is a viral infection. Okay. And it is common in children less than 1 year of age, but it may occur up to children of 2 years age. Okay. But the most peak age group is 3 to 6 months of age, and it has a seasonal preference, that is winter and spring season. Okay. So which virus is the causing bronchiolitis? The most common virus causing bronchiolitis is Respiratory Syncytial Virus or RSV. According to the Indian Academy of Pediatrics, it accounts for almost 75% of the cases of bronchiolitis. What are the other viruses causing bronchiolitis? These are the influenza, parainfluenza, adenovirus, coronavirus, rhinovirus, and remember there is one bacteria that is also causing bronchiolitis, that is Mycoplasma pneumonia. Okay, so most of the causes atypical bacteria. Most common cause is RSV. Remember it. So how does bronchiolitis occur? Very simple. Just look at the left side picture. This is the normal bronchial tubes. Okay, here is a normal tissue, normal epithelium, the smooth muscle is here relaxed, this is alveoli and this is bronchiole. So the disease is here, okay, in the tubes, not here. When the disease affects this will be termed as pneumonia, but we will discussing the disease pathogenesis here, okay. So in the tubes, okay, when the virus infects the bronchiole, there is necrosis and loss of the epithelium, okay, and there is mucus buildup in the tubes. So there is blockage of the tube, and you know that the resistance is inversely proportional to the fourth part of the radius. So when the tube is being occluded, there is resistance of the airway. So the child will having some difficulty in breathing. Okay, the smooth muscles also being tightened, okay, around the bronchiolar tubes, and as a result, when the obstruction is partial, it acts as a ball valve mechanism. The air is going in, but air does not come out easily. So there is trapping of the air. So there is air trapping, alveoli overinflated with air trapped air. So there is overinflation, and when the obstruction is persisting for a longer period of time, there is there is absorption of the air causing collapse of the alveoli. Okay. So next, coming to the clinical picture, how does a bronchiolitis baby present? So the most common age group is 3 to 6 months of age. It can happen up to 2 years of age. Okay, usually the presentation is with the baby usually comes with persistent cough, following a prodrome of coryza for 1 to 3 days. So there will be runny nose, then there will be persistent cough, and it is associated with low grade fever. As it is a viral infection, the fever is not so much high grade, there is low grade fever usually, and there is associated feeding problem, there is vomiting usually after 3 to 5 days of the illness, and apnea. Apnea may be the only presenting feature, particularly if the child is below 6 weeks of age. Okay. So next come to the signs of the bronchiolitis. These are the symptoms. What are the signs we may get in case of bronchiolitis? There will be nasal flaring. Remember, from the top to bottom there is a nasal flaring. Okay, there may be cyanosis. In severe cases you may get cyanosis. There may be tachypnea in the chest, and there may be auscultative findings may reveal wheeze or crepitations, and there is intercostal chest wall retraction, and the liver may be pushed down. Okay, liver is pushed down. There is no hepatomegaly, but due to hyperinflated of the chest, the lung is expanded, so the liver will push down of the liver. Okay. So next coming to the how we can classify bronchiolitis. Okay, severity according to severity. What is the importance of classify bronchiolitis according to severity? Because by this classification we will consider which baby will be treated at home and which baby needs admission. Okay. So these are the three parameters of classification: feeding ability, respiratory distress, and saturation. If there is normal ability of the feed, little or no respiratory distress, saturation more than 92% in room air, this will be termed as mild bronchiolitis. Okay. Then second is if there is respiratory feeding ability appear short of breath during feeding. Okay. So there is difficulty in breathing, moderate distress with some chest wall retraction and nasal flaring. If the saturation is less than 92%, that is corrected with oxygen, that will be termed as moderate bronchiolitis. And severe is the baby is reluctant or unable to feed, severe respiratory distress. Okay, marked chest wall retraction, nasal flaring or grunting, can have frequent and prolonged apnea, saturation less than 92%, that may or may not be corrected with oxygen, that is termed as severe bronchiolitis. So moderate and severe bronchiolitis needs admission. I am coming to the next slide. Then what are the differential diagnosis of bronchiolitis? First, pneumonia. You have already seen that the pathology is very closely related, bronchiole and alveoli. So also it is the symptoms are closely related, but my dear student, you can easily there are so many clinical pointers by which you can differentiate a case of bronchiolitis from a pneumonia. Okay, so pneumonia is very closely related diagnosis, but here the fever is one of the most important differentiating point. Here you will get a very high grade fever with persistent focal crackles. Episodic viral wheeze, it is our topic of discussion in the next session. So there is persistent wheeze without crackles and recurrent episode with or without a family history of atopy. Foreign body of trachea, here you will get a history of aspiration. The patient is come with acute episode of cough, and there you are getting localized type of localized wheeze. And the last one is congestive cardiac failure. Yes, it is the patient may present like features of bronchiolitis, but here you will get tachycardia, tender hepatomegaly, edema and crepitation in the base of the lungs. Okay. So investigation, remember bronchiolitis is a clinical diagnosis, you may not need any type of investigations, and investigation are mainly needed to differentiate, to exclude some other differential diagnosis. Okay. So it is mainly on the depends on the clinical diagnosis, depends on the age. As I have said, the bronchiolitis most common age group is below 1 year, but it can happen up to 2 years. But do not think bronchiolitis after 2 years of age. The most common age group, peak age group is 3 to 6 months of age. Okay. Then seasonal occurrence, it may happen all of the throughout the season, but most common seasonal preference is spring and winter. Okay. And then the typical clinical presentation, as I have said, the patient will come with coryza, cough, then feeding difficulty, vomiting, respiratory distress. In severe cases, you may get cyanosis and cyanosis. Even the patient may present with sometimes respiratory failure in very severe cases, advanced cases. Okay. So pulse oximetry is, I have already said, pulse oximetry, it helps to identify hypoxia and need for hospitalization. Okay. Admitted baby may need arterial blood gas analysis, complete blood count, CRP, serum electrolytes, and chest radiograph. Here you can see the chest, the lung is. Any comment from the X-ray? Sion, any comment? Lung is? This is known as perihilar shadow, and it is expanded. Okay. So in bronchiolitis, you will get the liver is normal than it is expanded. Okay. If you count the ribs, it is rib count will be more than 6. Okay. And for this region, you are getting the push down liver. So there is actually no hepatomegaly, just push down of the due to expanded lung. Okay. Treatment is focused on the symptomatic relief and maintaining hydration and oxygen. Mild bronchiolitis may not need any hospitalization. We can just send them home with saline nasal drop and frequent, either if the baby is breastfed baby, frequent breastfeeding, or if the baby is more than 6 months, the hydration should be maintained, but the parents should be counseled when to come back when they see the danger signs. Okay. So fever should be treated with a paracetamol. Nasal block should be cleared with saline nasal drop. Child should be made in propped up or head end elevation to make the airway pattern to help the child breathe comfortably. Orogastric tube feeding may be indicated in admitted patient. IV fluids in children with impending respiratory failure or who do not tolerate the orogastric tube feeding. Suctioning of the upper airway in children with apnea, respiratory secretion and feeding difficulties due to upper respiratory secretions. And supplemental oxygen is needed if the SpO2 falls below 90% if the child is more than 6 weeks, below 92% if the child is less than 6 weeks or with underlying heart disease. So oxygen is needed in case of children less than 6 weeks if the saturation less than 90%, if the child is less than 6 weeks, below 92%. Then CPAP, in advanced cases when there is disease is more severe, you may need the baby to be admitted in ICU. We may need CPAP in case of impending respiratory failure. High flow nasal cannula oxygen may have a role as a rescue therapy to reduce the proportion of those requiring intensive care. And drugs which are usually given but there is a broad census is lacking are hypertonic, nebulized hypertonic saline, 3% NaCl. If the child is hospitalized for more than 3 days, we can give a trial of nebulization with hypertonic saline. And if we can also use nebulized adrenalines. And when the baby is admitted, we can give a trial of beta-2 agonist, that is nebulization with salbutamol. If there is any improvement, we can continue it, but if there is no improvement, we should not continue and stop it. Then comes to the prevention. How can we prevent bronchiolitis? Okay. First and foremost is the breastfeeding. Breastfeeding offers a very good protection against bronchiolitis because the secretory IgA which is present in the breast milk offers a good immunity to the baby to prevent bronchiolitis in future. Hand hygiene is another most important thing because the disease spreads from one child to another child because due to poor hand hygiene. Okay, and we can prevent the disease by avoiding the passive smoking and immune prophylaxis. Recently, these are the drugs which are coming. That is one monoclonal antibody, that is palivizumab. Okay, just remember the name. And there is another drug that is nirsevimab and motavizumab. These are under trial. Okay. So next, coming to the next topic, that is which associated lower respiratory infections. This is also presenting like bronchiolitis, but remember when any child is coming with first episode of wheeze, that is termed as bronchiolitis. But when the same child is coming with recurrent wheezing, recurrent types of wheezing, the child is the terminology will be wheeze associated lower respiratory infections. Okay. So it is here the baby also coming with wheezing during discrete period of time. Okay. Following every time the child is having viral infection, the child is coming to you with wheezing, cough and wheezing, and with the absence of wheeze in between the episodes. In between the episode, the child is completely normal. There is no symptom. But whenever the child is having any type of respiratory infection, upper respiratory infection, the child coming with the wheezing, cough and wheezing. And these are the newer terminologies, that is episodic viral wheeze or under 5 wheeze or preschool wheeze. These are the new terminologies rather than using the old term Waldry. Okay. So if the child is coming with recurrent type of wheezing, how will you approach? Whether it is a case of asthma or not. Okay. So remember that every child who is wheezing is not asthma. So all that wheezes is not asthma. Okay. So how can we differentiate whether it is asthma or not? By asking the questions, that is onset of cough or wheezing. If it is insidious onset or sudden onset. Okay. If there is sudden onset, any cough or wheezing, that indicates what? Sudden onset cough and wheezing, any foreign body. Okay, I have already told it in your previous class. And duration of cough, how many days the child is having coughing. Okay, in case of Walry or episodic viral wheeze or under 5 years, the child is come with repeated long-term cough and repeated episodes of cough and wheezing. And timing of wheezing, it is mainly nocturnal or early morning cough. Okay, in case of wheezing. And type of cough is dry cough. Frequency of cough or wheezing is number of days per month. How many times the child is having cough should be asked. And is it perennial or seasonal? Is it throughout the year or it has a particular seasonal variation? Interval, so how the child is in between the episodes. I have told that in case of Walry, the child will be absolutely normal in between the episodes. And activity limitation, whether the child needs some school absenteeism or restricted play or not. What triggers the attack? Okay, any viral infection, smoke, exposure to dust, mold, cat, or grass or tree pollen, food in response to activity, exercise, laughing, coming. What triggers the attack? Okay, this should be asked for. Whether there is any history of allergy in the child or in the family, whether the parents are suffering from asthma or not. Documenting airflow limitation. If the presence of wheeze one or more times in the past, that is documented by a physician. This also supports the diagnosis of Walry. And documenting reversibility, whether the child is getting better after nebulization with some beta-2 agonist or not. And so it is very difficult to differentiate it from asthma or which there is an index by which we can predict that this child, when the child is coming with recurrent types of wheezing, we may predict that this child may develop asthma in future. So there is a index that is known as modified asthma predictive index. Okay, so by this index we can predict that this child may develop asthma in future. Under 5 wheeze is not asthma, but if by this index we can predict asthma. What is the index? That is, it is used for the children below 3 years of age with all of the following. That is, if the child is coming with more than 3 episodes of wheeze, 4 episodes of wheeze in a year. Okay, in a calendar year, the child is coming with 4 episodes of wheeze. Okay, and there should be 2 major criteria, one major criteria and 2 minor criteria. What are the major criteria? If there is physician diagnosed parental asthma in the parents, or physician diagnosed atopic dermatitis in the child, or allergic sensitization to allergen, aeroallergen, okay, dust mite, cat, dog, mold, grass, trees, weeds, etc. So any one may be present. Major criteria only one is needed, and minor criteria one of the following. That is wheezing unrelated to colds, blood eosinophil more than 4%, and allergy sensitization to milk, egg or peanuts. Okay, so 4 wheezing exacerbation in 1 year along with 1 major criteria or 2 minor criteria. That is sufficient to predict whether any child will develop asthma in future or not. Next, what are the differential diagnoses if a child is coming with recurrent wheezing? Common causes are laryngotracheomalacia, already discussed in the last class, foreign body aspiration, GERD, gastroesophageal reflux disease. What are the infections? That is TB present with types of symptoms. PBB, that is protracted bacterial bronchiolitis and immune deficiency. Some congenital condition may present with recurrent wheezing like congenital airway anomalies, congenital heart disease, congenital vascular anomalies, and some rare causes cystic fibrosis, ciliary dyskinesia, chronic lung disease or hypersensitivity pneumonitis. Okay. So what are the investigation needed? That is complete hemogram. It may support, if there is eosinophilia, that may support the diagnosis of asthma. Already told, if there is eosinophil more than 4%, it will come as a minor criteria. Chest X-ray just to rule out alternative condition, and allergy test is done to document allergen sensitization in those who report allergic symptoms on exposure to particular allergen. Spirometry useful only in case of children above 5 years of age. So what are the treatment options? If the child is coming with infrequent episodes of wheezing, that is not more than 4 episodes of wheezing per year, we should give salbutamol, only bronchodilator. Okay, the treatment should be given by metered-dose inhaler. Oral therapy is not recommended. Inhalation therapy is always better than the oral therapy. So if the child is, according to Indian Academy of Pediatrics, if the child is under 4 years of age, we should give them MDI with spacer with mask, but above 4 years we can give them only MDI with spacer. The mask should be removed as soon as possible. The child can breathe through the mouthpiece. Okay. So if the child is presenting infrequent types of wheezing, not more than 4 episodes of wheezing, but if the child is presenting with more than 4 episodes of wheezing, what should we give? Only salbutamol or something else? No, or not only salbutamol is sufficient. We should give them some reliever, just like asthma therapy. Okay, here we will give them budesonide, steroid, inhalation steroid. Okay, inhaled corticosteroid, ICS, that is budesonide. If the child is presenting with 4 episodes of wheezing in a year, okay, so you can give them ICS, a trial of ICS, that this child may develop asthma. So we can give a trial of ICS, that is 3 months trial of ICS, that is budesonide 100 milligram twice daily. Okay, if there is improvement, we should look at this chart. If there is improvement, good response by giving the ICS, okay, 100 milligram twice a day for 3 months. Good response, we should stop ICS after 3 months and follow up. If there is again recurrence of the symptoms, we should again start this ICS. But if there is no benefit after 6 months of starting therapy, there is no need to continue the therapy. You should stop medication, revisit the diagnosis and rule out other causes of wheezing. Okay. Then coming to the most important part of today's discussion, that is pneumonia. What is pneumonia? I have already told that pneumonia is the inflammation or by some pathogens in the alveoli, in the air sac. Okay. So pneumonia is an inflammatory condition of the lung, primarily affecting the small airway sacs known as the alveoli. Okay. And it is the most common cause of under 5 mortality till date. There are 3 types of pneumonia, that is community acquired pneumonia, that is the pneumonia is developing in the community. Then hospital acquired pneumonia, when the pneumonia is occurring after 48 hours of hospitalization, and there is ventilator associated pneumonia, that is when the child is developing pneumonia after 48 hours of giving some intubation. Okay. So what are the etiology of pneumonia? This chart is taken from the standard textbook of Nelson Pediatrics textbook. In children below 3 weeks of age, the main pathogen is gram-negative organism, that is E. coli, and in 3 weeks to 3 months, yes, no, the main cause is streptococcus, may also cause streptococcus pneumonia, group is streptococcus, but below 3 weeks, the most common pathogen is gram-negative organism. In 3 weeks to 3 months, respiratory syncytial virus along with other viruses and bacteria like streptococcus pneumoniae, H. influenzae, and 4 months to 4 years, again the viruses and the bacteria streptococcus, H. influenzae, also some atypical bacteria like mycoplasma. And more than 5 years, the main causative organism is mycoplasma, atypical organism, mycoplasma. So in this age group, the causative organism is mainly gram-negative. Here viruses and the typical bacteria, and more than 5 years, mainly the atypical bacteria. Okay. So what are the pathophysiology of pneumonia? When there is infection of the alveoli by the pathogens, there is causing some immune system response, which causing inflammation and leaky alveolar walls and pulmonary capillaries. Okay. So the alveoli capillaries, this is the alveoli, they are filled with fluid and pro-inflammatory molecules and blood cells and pathogens. So the alveolar sac is getting filled with some of these materials, so there is gas exchange is impaired. Okay. So the pathology in pneumonia is in the alveoli. So how does a pneumonia patient presents? Pneumonia patient presents with high grade fever, cough, but cough may not be very prominent. And there is breathlessness, difficulty in feeding, tachypnea may be present. There is, in severe cases, you may get cyanosis and altered sensorium or convulsion. So this is the WHO classification, revised classification of pneumonia. Very important chart. According to their symptoms and signs, they are classified as no pneumonia, pneumonia, severe pneumonia, very severe pneumonia. Okay, no pneumonia. What is no pneumonia? There is only cough and cold. There is no fever, no fast breathing or chest indrawing. What is pneumonia? When there is fast breathing. What is fast breathing? Fast breathing. What is fast breathing? Yes, tachypnea, but there is a cutoff respiratory rate. If the child is below 2 months, the cutoff is 60. If the child is more than 2 months, below 1 year, cutoff is 50. 1 year to 5 year, cutoff is 40. More than 5 year cutoff is 30. Okay. Right. So if there is fast breathing and chest hindering, that is pneumonia. If there is fast breathing, chest hindering along with these symptoms, okay, these signs, that is child is not able to drink or feed, persistent vomiting, convulsions, cyanosis, lethargy, unconsciousness, stridor, severe malnutrition, that is severe pneumonia. Okay. So pneumonia, no pneumonia, pneumonia and severe pneumonia. Okay. And the last line is very important. The persistent single cardinal sign which is very sensitive and specific to diagnose pneumonia is tachypnea, tachypnea and tachypnea. Okay, without tachypnea, pneumonia is very unlikely. Okay, the respiratory findings, that is crepitation, may not be present all the time, but tachypnea must be present to diagnose a case of pneumonia. Okay, so this chart is very important. Investigation, what are the investigation? The community acquired pneumonia is a clinical diagnosis. Again it's a clinical diagnosis. You may not need any type of investigation, but investigation is required when in case of child is admitted to a hospital. What investigation? Blood count, blood culture, chest x-ray, inflammatory marker, etc. Here is the consolidation, okay, right upper lobe consolidation, okay. This is the consolidation, homogeneous opacity in the right upper lobe, okay. সব গল্প করছিস শুনছিস না ভালো করে ইম্পর্টেন্ট ক্লাস কিন্তু so indication of admission in case of pneumonia. What are the criteria for admission? If the child, remember, if the child is below 3 months, there is no entertainment or in your outdoor, okay, the child should be straightforward admitted to a hospital. Okay, because below 3 months develop any type of complications of pneumonia, so there is no role of giving oral antibiotics. The child should be admitted in a hospital. If there is severe malnutrition or feeding difficulty or the child looks dehydrated, the child should be admitted, okay. Severe malnutrition or dehydration or feeding difficulty. Next, if there is oxygen saturation is less than 92%, if there is intermittent apnea or grunting, there is a marked tachypnea. That marked tachypnea means 20 breaths per minute above the cutoff. If the child is, say for example, if the child is 3 months age, so what do we mean by marked tachypnea? 3 months age. What is the cutoff for 3 months age? Respiratory rate. What is the cutoff value of respiratory rate? 3 months age, 50. If the child is presenting with more than 70 per minute, that means the child is having marked tachypnea, and in this child, the child should be straightly admitted to a hospital. Okay. If there is failure of outpatient department, if you have already tried with some oral antibiotics, but the child is not responding clinically, the child should be admitted in a hospital. So what are the treatment of oxygen in OPD? That till now the drug of choice is amoxicillin, not amoxiclav. And if the child is admitted, the injection ampicillin or injection coamoxiclav. In severe cases, we should give third generation cephalosporin like injection ceftriaxone with cloxacillin or vancomycin in case of VRSA. And if there is atypical pneumonia, we should give azithromycin. Next, coming to the one of the most common complications of pneumonia, that is empyema. Okay. So it is commonest complication of pneumonia. Yes, commonest complication of pneumonia. And what do you mean by empyema? There is collection of pus in the pleural cavity. Okay. It is commonly seen in case of post-measles pneumonia. And the causative organism in case of immunocompetent patient, the causative organism is Staph aureus followed by Streptococcus pneumoniae, Streptococcus pyogenes or Haemophilus influenza. If the child is immunocompromised, gram-negative organism and fungi are the etiological agent. So what is the pathogenesis of empyema? How the empyema is developing? The child is having pneumonia followed by, if the child is not treated properly, the child may develop pus in the pleural cavity. That is termed as pneumonia. How the pus is developing? Okay, the child is having pneumonia. Now the child is having empyema. How? Look at this chart. First, there is 3 phases. The pus develops in 3 phases. First is exudative phase, then fibrinopurulent phase, then organization phase. I am making it trying to simplify this. Here, the first, there is first 1 to 3 days, the fluid is thin with minimum cellular response. Okay, this side is this is the outer side, and this is the inner side. Okay, so when the organism is there is infection, so this causing the damage of the pleural epithelium, that is mesothelium. So there is damage of the epithelium and there is no cellular response within the 1 to 3 days. After after 3 days, that is in between 4 to 14 days, the pleural fluid shows large number of polymer. There is polymorphonuclear neutrophils, okay, and fibrin deposition. So in this stage, the pus is getting formed. So there is pus formation, and in the last phase, after 14 days, there is fibroblast grow into the exudates on both visceral and parietal pleural surface, producing an inelastic membrane that peel that entraps lung and prevent expansion. So first there is fluid formation, that is thin fluid, then there is deposition of the neutrophil along with the fibrin, that is known as fibrinopurulent stage, where the pus is forming in this stage. In this stage the pus is forming, and then last there is formation of the inelastic membrane that prevents the lung from expansion. Okay. So presentation, where we will suspect a case of empyema. Suspect empyema if the child admitted with pneumonia fails to improve within 48 hours after initiation of appropriate antibiotic. You have given the antibiotic. You have admitted the child, you have given the child antibiotics, but the child is not responding. After 48 hours of giving antibiotic, the child is again febrile, child is having respiratory distress, then you should think of empyema, that this child probably have developed empyema. Okay, the child looks, how the child looks, the child will ill with high grade fever, malaise, loss of appetite, breathlessness, cough and chest pain. Chest pain is very much significant. If a child is pneumonia, is complaining of chest pain, the child is not responding after giving antibiotic, you must think of empyema. And the child may lie on affected side. So decubitus of choice is on the affected side. If the child is having empyema on the right side, the child is always prefers to lie on the right side. Okay. Why? To splint hemithorax for temporary analgesia. On examination, you will get the child, sick looking child, that is respiratory distress, reduced chest movement and expansion, dull note or percussion. There is pus, so you will get dull note or percussion, reduced or absent breath sound and scoliosis on the affected side. What are the investigation? You will need some blood count, that will show total count will be raised, CRP raised. You should do the electrolytes, blood culture should be sent, and total protein albumin should be sent. Chest X-ray should be done, USG to identify the nature of the fluid, and CT scan should done. For CT scan, it identifies the underlying lung parenchymal necrosis or abscess or thickening of the pleura and helps surgeon plan for the surgical treatment. And pleural fluid examination should be sent. What are the treatment option? First and foremost, you should give supplemental oxygen. If the child is admitted not able to feed, you should give the IV fluid. We should give paracetamol to relieve fever and pain. Then the mainstay of treatment is antibiotic and intercostal drainage in our setup. Okay. So what antibiotics usually? Third generation cephalosporin along with cloxacillin or vancomycin. We should modify the antibiotic according to the culture report, and duration of therapy, remember, 2 to 4 weeks. But we can switch to oral therapy if there is clinical improvement. Intercostal chest drain, as you see in the picture, chest drain should be given to remove the pus in a container. If the collection is less than 50 ml per kg per day for 3 consecutive days, we can remove the drain. And in advanced setup, we should give fibrinolyte if there is adhesion. Open decortication is another option, and video assisted thoracoscopy surgery done mainly in foreign country, not in our country. So this is the management option. If there is stage 1, that is exudative phase, we should give antibiotics along with ICD. If there is stage 2, antibiotic ICD with fibrinolyte or VATS. But in case of stage 3, there is no law of antibiotic or ICD. We should straightly go for VATS. Okay. So any questions? We have time. You can ask question. Today there is no MCQ, but you can ask question. If you don't ask me question, I will ask you questions. Very simple questions. Bolo, stand up. What is the most common virus causing acute bronchiolitis in children? Most common virus causing acute bronchiolitis. Yes. Full form. Mic আছে mic. RSV, respiratory syncytial. So he has said correctly, respiratory syncytial virus. Okay. Which antibiotic will you give it is a case of acute bronchiolitis. Which antibiotic will you give? First line of antibiotic in case of acute bronchiolitis. Which antibiotic? Acute bronchiolitis. You have seen a case of acute bronchiolitis. Now, which antibiotic? Will you give antibiotics? Yes. Then which antibiotic? Ceftriaxone. ঠিক বলেছে? Acute bronchiolitis. Acute bronchiolitis. I have, huh? Follow? Viral. So there is no role of any antibiotic if it is a case of acute bronchiolitis. So there is only if the child is mild bronchiolitis, we should give only hydration and oxygen. Okay. But if the child is severe, then we should admit the child and treat according to severity. Okay. There is no role of any antibiotics. Okay. So these basic questions. Okay. Next.